So tonight's mission, we're going to be talking about family medicine. I'm excited about that. I'm also excited to hear these stories. But what I'm most excited about is to create this platform and help not only our HPSV students across the nation, but also to help us engage with potential medical students and get people excited about military medicine. So our few of the groups that are helping us along the way. If you haven't checked out the USAFP, it's the Uniformed Services Academy of Family Physicians. On their website, there are a lot of great resources as well as places to find mentors and more potential. Again, we are definitely working USU hand in hand with our Army, Navy, and Air Force HPSP teams, and we'll see the breakout rooms at the end of the lecture. I encourage you, if you're a pre-med interested in medicine and you're interested in a particular service, there will be a place for you to go and meet and greet. If you want to hear more cool stories, check out the War Docs podcast. Lots of stories from Afghanistan, Iraq, and before, and then even some more recent. Again, I work at USU, the Uniformed Services University, and in coordination with all these groups, we're creating this military medical community for our HPSP students as well as for the pre-medical students that are out there. We are trying to we're launching a website that you get to it through the USU website, but it's under resources, under the School of Medicine, military medical communities. And the goal is to have the calendar of events as well as resources. So if you want to find that War Docs podcast or other questions about HPSP, that's there for you. But I will turn it over right now to Dr. Knoll, who will introduce Icon, our first speaker this evening.
All right. Hello, everyone. Thank you so much for joining us. I'm Lieutenant Colonel Mary Alice Knoll. I'm an Army family physician, and I'm so thrilled to be able to be here with you tonight, wherever you are calling in from, and introduce some fellow family physicians who are just absolutely incredible to you tonight. So I know that they're not going to toot their horn, but I am going to say that all three of these physicians have had tremendous impact on our community of family medicine. All are very involved or have been involved when they were serving in the Uniformed Services Academy of Family Physicians. That is the military chapter of the AAFP. And so that is something you can join as a student, get plugged in for resources, and we can put the link to the USAFP website as well. So let's get started. So Lieutenant Colonel Rosalyn Icon Fuentes, and so that's an Air Force thing, I'll let her explain that, is going to go first speaking with us. And thank you so much for joining us tonight and sharing your story with us.
Once again, thank you again for the invite to speak at the Military Medical Community Meeting. I'm very excited to share some of the exciting things we get to do in both family and military medicine. I like to start with, let's see if it put up, there we go, this meme. And I think that pretty much summarizes what we're going to talk about today. I'm hoping to emphasize the vital importance of solidifying your family medicine training if you decide to go into that, which will prepare you for success as an operational doc. I will say that military medicine does present a lot of cool and unique opportunities. You get to integrate into operational units, practice occupational medicine, dabble a little bit in public health, and obtain a lot of unique skill sets. However, your first job, and no matter what you decide to do, is going to be being a good doc. You're going to be facilitating administrative tasks to help your patients continue to do whatever their job is, whether it's flying planes, kicking down doors, or just maintaining their constant readiness. So, as mentioned before, we are all going to be operational, whether or not you're going into an OG&E vector track in flight medicine or not. Chances are high at baseline you're going to deploy as family medicine. And you can ask any of the attendings here. And with the rapidly changing political environment, that chance is even higher. Additionally, we have future conflicts. We're looking at near-peer adversaries where air superiority is not going to be a guarantee, and that's going to further limit our timely evacuation. Another key buzzword we're going to hear a lot about is LSCO, large-scale combat operations. These are be warfare of attrition, very large number of casualties. We have an inability to evacuate patients and medical resupply by conventional means as previously developed in our war of terror. So we're looking a lot at prolonged care, which is necessarily going to be a certainty on the front line of troops. But fortunately, if you go into family medicine, this is all something that we're all equipped and trained to do. So before going into the meat of the brief, I like to talk about the why, right? And the why should be really what defines what drives us. For for me, my parents were immigrants. I grew up appreciating the privilege of being an American, and I knew I wanted to be able to serve and give back in some way. I picked family medicine in particular because my end goal after the military was to do something humanitarian related, like Doctors Without Borders, International SOS. So I wanted a wide skill set. A large reason also for going to family medicine were my mentors at USHIS, and I'm very humbled and honored to be speaking alongside one of them today, Dr. Stevens. So I'll say in general, I'm actually very happy I did family medicine. It's been very helpful in my practice in the military medicine. In particular, I did flight medicine later on in my career due to the feeling of direct impact and integration that you can do as a flight doc into the operational mission. So you had many opportunities there that are unique. You can be embedded in the flying unit. You can deploy with them. You can do things like AE, where you're doing patient transfers. There's some unique opportunities if you want to get double wings as a pilot position. You can do international health, building international relations and traveling, and then more beyond the wire jobs like combat aviation advisors. A little bit more background, like commissioned from ROTC in 06, graduated USHIS in 10, and I completed family medicine residency at Nellis in 2013. Of note, family medicine in the military has a long history. Eglin, where I taught for 5 years as faculty, was actually the second family medicine residency that opened in the country. And in general, too, family medicines have a historic high board pass rate in military medicine. Training in your family medicine residency will include taking care of your military population and their families, as well as some civilian rotations in peds, trauma, OB. So I felt very well prepared for an operational career. In addition, in the military, there's never-ending opportunities for training postgraduate. So additional training I completed was in faculty development, wilderness medicine, and medical acupuncture and tropical medicine. These are all opportunities that are available through annual scholarships that are offered, as well as through USHIS. After residency, I served as a PCM in the family health clinic and adjunct residency faculty. And then I transitioned to full-time faculty for about 5 years, which is a very rewarding experience as I continue to see a lot of the former students can make a difference. However, no matter where you go, the need to practice good medicine is the same. But in military medicine, you have a lot of occupational considerations. You need to think about what members do for their job. Are they pilots, jumpers, BUD, security forces? Are they able to deploy to austere environments? Fortunately, family medicine is uniquely poised to take care of a wide variety of medical issues, procedures, and patient demographics. And I strongly believe completing a residency in family medicine, along with a few foundational years after practicing full-scope family medicine FMR, created that strong foundation that allowed me to be successful in operational medicine. For the past 6 years, I've been in flight medicine after completing AMP, as our flight surgeon training, and additional required training in SEER, where I learned that woodchuck ants and tree bark is edible. As a flight surgeon, I've flown over 300 hours in 15 different aircraft, from the F-16s, AC-130 gunships, and everything in between. 2020, we worked closely with the line for COVID mitigation. We were dealing as well at the same time with 3 Class A mishaps, including 2 ejections, and covering numerous in-flight emergencies, such as rapid decompression requiring hyperbaric treatment. And actually was able to have the opportunity to actually edit the F-16-1, that's our handbook, essentially, for overpressurization management. And actually who helped me and took the lead on that was actually a brand new graduated family medicine doctor, Dr. Beth Burbrick. And then also in military medicine, you'll get an opportunity to take leadership roles. While I was in flight medicine, I was a flight commander twice and a medical director many times. I served overseas as SGP, or Chief of Aerospace Medicine in Korea, and the Wing Public Health Emergency Officer for the 8th Fighter Wing, affectionately known as Wolfpack. There's a lot of history there. You might recognize one of the guys in the middle, Robin Olds, Wolf 1. Definitely a lot of MOP 4. It's a very operationally busy base, a lot of heavy flying hours program. But as an SGP, I was able to see how we built the connections between the medical group and the line side. Definitely one of the best jobs there as a flight surgeon. I recommend it. Some additional pictures, some jump coverage we're doing at the AFSOC and ROCAF jumpers, AE training with the Army Chinooks. Did some exercises. You see us all in the MOP 4, very comfortable, Mount Fuji off the wing of a C-12. And just basically a lot of support of a fast-paced fighter wing. My next job took me a bit of a different direction. Currently, I work at AFSOC at Hurlburt. Special tactics are the special operators of the Air Force, including PJs and combat controllers. And their duties are very different. They include jumping, diving, combatives, and shooting. Currently, I'm the medical director over at the Special Tactics Training Squadron, basically their schoolhouse. Focuses on fitness and health preservation of tip of the spear operators. So a lot of outdoor time, range coverage. For example, one of my work weeks, we had a 13-mile ruck, which I rucked with them. We did some day and night coverage with jumps, clinic, of course. And I flew on 2 different aircraft where I was able to multitask and write a few waivers. You get a lot of opportunity to attend different trainings, such as airborne or free fall. And I just completed dive school in the past year to be a dive medical officer. In regards to research, in 2016, I took on the role of the medical group director of clinical research. And with the motivated group of students, we increased our research output by 300%. My particular passion is operational research and how we can look at and study the best practices for this unique brand of medicine. Picture above is from Operation Blood Rain. We look at the feasibility of delivery of fresh whole blood via airdrop to the point of injury. Currently, we are working with the Joint Trauma System to create operational practice guidelines or SOPs for aerial delivery of blood products. So keep an eye out for that. So one thing I get asked and comes up many times again with students, do we really need that full scope of practice, right? Is cradle to grave training really relevant in military medicine? Do we need obstetrics? Do we need newborn care? So to answer that question, I could tell them, a story. In 2016, I deployed to an undisclosed location. And in general, deployments are a great opportunity for you to gain context and perspective to see why we train the way we do. I was learning how to practice medicine in an environment with limited resources and unique stressors. We had scorpion envenomations, medevac. We had for an incarcerated bowel, acute appendicitis. We had a retinal detachment. Mental health, of course, and emergency medicine, lots of musculoskeletal stuff. I utilized acupuncture, joint injection, dry needling quite a bit. And a previous rotation, I actually delivered a baby and unexpected pregnancy in the clinic. And we often use our ultrasound to determine gestational ages. I deployed again in 21 in support of Operation Allies Refuge, helping medically clear and settle over 64,000 Afghan refugees. I used my training as family medicine, caring for all ages from newborn to the elderly. And we had a lot of unusual, untreated medical conditions, including an 8-year unrepaired tetralogy of Fallot, which is typically repaired right after birth in the United States. We also had concerns for measles in an unvaccinated population, and also it was during COVID. And then I was able to use our flight medicine training to aeromedically clear complicated medical cases for flight. So just full scope of family medicine right there in that one deployment. Some of the unique challenges of operational medicine is diagnosing and treating pathology, as it is in all medicine, but we're also taking care of normal physiology and abnormal environments, and that is often resource constrained and contested. And some example in these pictures, you'll see in medevac, aerovacs, prolonged field care, EMEDs, whole blood transfusion, and you might even have to defend yourself and your patients. So you get training for that as well. So this will be you. I think it's can be hard to picture yourself in a lot of these situations, but in this picture, these are all brand new graduated residents, primary care physicians, their first assignment overseas, and it was a 1-year unaccompanied tour. They had minimal senior physicians and specialty availability, but luckily they all felt very well prepared by their family medicine training. All right, and then I'll answer questions at the next in the next room.
Thanks, Icon. That was awesome. Sounds like you've had a pretty awesome career. What can you give us one piece of advice that you would give to either a pre-med or somebody in the, first, second year of med school?
I think it's just be curious, be willing to challenge yourself, be comfortable with being uncomfortable. I think even now, I don't ever see that meme where you're trying to look for the 10-year attending. And I still feel that way. 19 years in, I feel like there's always going to be situations where this is not exactly what we train for. But I think in the military, you learn that your strongest resources are going to be the people around you. So I think you just get comfortable pushing yourself to the limit. You try to train as best and prepared as you can, of course. But I think you're just usually lucky you have a good resource and network to reach out to. So I think as a student going into that, keeping that mindset, just like be curious and be willing to be uncomfortable. Ask questions if you don't know. Just constantly be learning and be comfortable with the never-ending process. You graduate med school, you graduate residency, you're still learning something new every day.
I love it. Totally agree. It's like figure out how to be innovative when you don't have a complete data set. So thank you so much for your time today. Really appreciate it.
All right. So I am so excited to introduce my colleague, Dr. Colin Hugh. Has done many things in his career, and he's about to share with you some neat videos. And really excited to appreciate, and I really appreciate his time as he is quite busy down at Fort Bragg. So take it away, Colin.
Hey, thanks, Mary Alice. Hey, everyone. As she mentioned, my name's Colin. I'm currently the Deputy Command Surgeon over here at Fort Bragg with the unit out at USASOC. And so hopefully, following after Icon, going to talk a little bit about my career path a little bit and how family medicine in the Army is very unique and the different things that I've been able to do and be blessed with, especially in my career. But kind of give you a little background on myself. So I grew up in a military family. My dad actually did 30 years in the Air Force as a dentist. And so all I've known really in the is a military life, right? To the point that I'm actually the black sheep of the family because pretty much everyone else in my family is Air Force and I'm the only one that's the Army. But undergrad, I felt, again, that urge to serve. So I decided to, when I was at Virginia Tech, join the Corps of Cadets. But I didn't know in what capacity I wanted to serve. So freshman year of college, I decided to get my EMT basic and join a Blacksburg Volunteer Rescue Squad. So going to the next slide, if you don't mind. So that was a pretty formidable decision and something that spurred the pretty much career paths going on forward. Because sophomore year back in 2007, I was involved as one of the medics involved with the shootings at Virginia Tech. And from there, I recognized like medicine was my passion, and being able to treat patients and take care of people was definitely something that I was very passionate about and something that I wanted to do. What I recognized too, working in the back of the ambulance, was that once I dropped the patients off in the back of in the ER, I didn't get to know what happened afterwards. And so that definitely spurred the decision to apply to medical school. And that's where I decided to go to BCOM, also known as the Edward Bia College of Osteopathic Medicine, also in Blacksburg as well. And it was super fortuitous, right? Because I was able to do the HBSP scholarship through them. And it was an amazing experience, if only because, one, you have the opportunity to be able to, or at least the flexibility to have that civilian interaction. But because VCOM is where it's located and through the HBSP scholarship, I had the opportunity to work with various different military treatment facilities as well. So I got to work out of what used to be Fort Lee, I think it's now Fort Greg Adam, and work with the pediatric department there. I got to work with the Navy over at Portsmouth Naval doing OB-GYN. And then before that, I was able to work at Womack Army Medical Center with several different rotations. And that actually helped guide me towards doing family medicine, because it was through them and through a couple mentors, specifically actually Colonel Raruka now, who's a program director over at Fort Hood, was an intern when I was a medical student at Womack, and showed me just how broad a scope family medicine was and the opportunity to be able to take care, literally, as I kind of mentioned, that cradle to grave. Really, you get trained all through your 3 years residency to follow a woman through 9 months of pregnancy, deliver that woman yourself, and become that child's pediatrician that gets old and dies, right? So you get that whole perspective of medicine, which was amazing to me and something that I really loved, especially that continuity of care and really getting to know your patients on a personal level versus one that is quick and easy and you don't really get to know them or their family, right? So that, as I said, if you can mind, go back to the other slide. So that's why I chose Womack, right? And it's also another reason. One, because I knew the facility, I knew the people, I knew who I was going to be working with and learning from, which was key, because I knew that kind of personalities and I would mesh. I also recognized at the time, and something you may want to consider when you're looking at your residency program, is how you learn. So at Womack specifically, I knew I learned more so by doing than by learning by didactics or lectures. And at the time, Womack only had 2 residency programs, Womack, or family medicine and OB-GYN. So you were really responsible as a family medicine doc running the inpatient ward, the pediatric ward. If you had family medicine OB patients, you're in charge of that. But really, as a family medicine doc, you really get the full breadth and experience to do so at Womack. Further on my career, I had the little seed that was planted again at Bragg of doing sports medicine. A lot of times because of the operational experience you had at Womack and the people you get to work with, both from a conventional side, say like the big 82nd Airborne that people hear about, and also the special operation elements that are here at Fort Bragg as well. And that planted the seed for me to do sports medicine fellowship and focus on MSK and procedure based, like needles and PRP and ultrasound guided injections later on in my career. Go ahead and next slide. So right after residency, especially my third year residency, I was asked to come and assess for the 160th Special Operations Aviation Regiment, also known as Night Stalkers. If you've seen Black Hawk Down, that's pretty much in the helicopters. That's the organization that I was privileged to be a part of for the majority of really my career right now. And from there, I was able to do a lot, both from learning and growth as a family medicine doc, but also just the unique opportunities that the Army has to offer, whether it be traveling to the special places. For example, that top left picture, I was able to go to Jerusalem and work in Israel for about 2 weeks in 2021. And part of it was actually getting a tour of Jerusalem, and that's actually where apparently Jesus was buried as well. And then everything from the airborne jump in the bottom left and jumping out of a helicopter, which is always super cool. Doing training in the back of a aircraft while the doors are open in the middle of Iraq, and that's where I'm getting an IV in the bottom right picture. Or the top right photo, recognizing that there are actually places in Iraq that are actually green. So that's the northern part of Iraq in Kurdistan. And ironically, we also found out in the back of a Chinook, you can put a couch back there and actually sit pretty comfortably looking outwards. But with that, like understanding like the Army has all these unique opportunities, and it definitely would not have been possible without, one, joining, but also doing family medicine, because especially in special operations, I found that the majority of people are actually either ER or family medicine, looking at specific operational roles. So after that, the 160th, I actually did the fellowship, as I mentioned. I did a little bit of time as staff at Womack as a faculty member, teaching sports medicine, and then now I'm currently where I'm at within USASOC. All right, next slide. So as I mentioned, family medicine is going to give you a lot of different training, right? It's going to teach you about not only being able to take care of people in austere environments with limited supplies, but also be able to take care of people back home. But the Army will also give you a bunch of training that will help you with your job, period, regardless of what you're doing. So if you're doing aviation, they're going to send you to the flight certificate course, which also may include or may not include something called dunker training, where you learn how to survive a vehicle or aircraft, specifically a helicopter, that has a ditch in the water, and how you can use your landmarks to get out of that aircraft hopefully in a safe manner. You also have the opportunity to eventually do hoist training, which is what that top right photo is, where you get to learn to be able to secure a patient to a SCEDCO, do the ham-arm signals, and get that hoist hook down to you to get that patient out from a very confined area. Or you might find yourself on the side of a mountain, which is on that top photo, doing some heli training, where you get to fly a bunch of people up to the top of the mountain. They ski down the mountain, you pick them up and you bring them back up, and you can make little snowmen in the back of the helicopter, which is a pretty cool memory and a pretty cool experience. But I would say one of the other things too, not only are you able to have the opportunity to do all these military trainings, but a lot of medical unique trainings as well, such as like the Special Operations Aviation Medical Indoctrination course, which is part of what we call the pipeline through the 160th, where you learn how to do trauma in the back of a helicopter. And you also get a little bit more ultrasound guides, you get a little bit more other trauma training, and you can teach that to other people as well. So that's what I got to do in the top left corner in our little med shed in the middle of Iraq, be able to work with other people, different services and different branches, and kind of go over what we learned to be able to share that knowledge, because in the end, we're all just trying to take care of the same people, right? And get them back home okay. All right, next slide. All right, but the best thing, kind of similar to what Icon's mentioning, is why we do what we do. Really, it's that relationships, being able to take care of people and get to know them on a personal level. One story I love is I was stuck in my first deployment ever in Syria, and my wife actually called me and said, "Hey, the siding on the other side of our house is coming off. What do we do?" And I'm like, all right, well, let me see what figure it out. And the next 30 minutes later, she texts me and says, "Hey, don't worry about it. One of the pilots already came by and fixed it for us." I mean, that's the type of relationships and respect and mutual rapport that you're going to get, an opportunity to achieve, especially the people you get to take care of, right? One of the best things I love saying is no one cares how much you know until they know how much you care. And that's truly the case, especially within the military, within the Army, and especially in operational medicine. As a family medicine doc, you know you made your mark, especially when they call and say, "Hey, doc, I've got this concern for my son or kid. Can you help me out?" No, absolutely. Love to do so. And really, These couple pictures are one of my favorite ones, especially like the top left one. That's the crew that I flew with the last time I was in Afghanistan. Because they're all, are super humble people, but you would never know one of those people in that photo has a silver star, right? On the top right photo, those are brand new people willing to train, and we're doing hoist training in the middle of Iraq, which is awesome. Being able to have that people willing to learn and want to learn and be able to get really blown away by rotor wash and willing to get eaten by rocks and everything else. But because they want to learn and help out, that's super special. And of course, the unique opportunities like jumping with your PA and your medics, which is what that bottom left one, or even just the bottom right photo was one of our other deployments we had in the middle of nowhere. And it was kind of crazy for that one, but you can see we're all smiling because we want to be a better place other than maybe home, but that's the group of people that you want to be with, right? Okay, next slide. So one thing too, we talked about a little bit of research, and I'll quickly go through this. If you hit the button, if you don't mind for playing that picture. So that's a Carl Gustav. That's and you can see the reverse. And we're talking about why we do research. We do research mainly to maybe affect change, but as a family medicine doc, you actually have the opportunity to do so in the military because the command's going to listen to you and say, "Hey, doc, what do you recommend for risk mitigation, et cetera?" So for mine, my passion was concussions. My concern was repetitive blast exposure specifically. And so one of the airframes we have is a Black Hawk outfitted with a minigun and a 30 Mike cannon and sometimes rockets, which is what that bottom left photo is. If you look at it, if you zoomed out a little more, the end of that barrel is about 4 feet away from the pilot's heads. And inside that crew chief as well is eating all that blast wave. So by the end of it, they're all feeling like their headaches, they're feeling like they're nauseous, and sometimes they're just puking outside the helicopter. So we're trying to figure out why. But you can't mitigate risk until you really identify the risk. And so as the flight doc and as family medicine doc, being able to translate medical concerns into engineering concerns and commander speak, if you will, of what risk is and how we can maybe prolong the life and maybe the health of our pilots and crew chiefs pay dividends. So we were able to work with Vanderbilt and create this 3D biophonetic head form on the right side with a brain gel inside and be able to determine exactly what type of exposures or PSI exposures these pilots and crew chiefs are having, to a point that we were able to make on that middle photo a shroud over the minigun to kind of provide a little bit of a barrier associated with it. Okay, next slide. So one of the things that's pretty cool too is you get these unique experiences, right? This is a little bird, a tactical bird over at Range 19 at Fort Campbell. So one thing, I'll kind of give you a play-by-play. So he's doing an initial attack at a point. So he'll zoom in, he'll do what we call a bump. So he'll fly up, hit an apex, and then literally drive the aircraft into the ground while shooting. You'll see the second helicopter as well. The second helicopter is going to provide support and security while that first one is pretty much exposed. And then once they finish attack, the second helicopter will then drop and then be able to hit that same target and then break at the last second. So one of the things that you want to consider, especially, again, you get this experience, you get paid to do this, you get paid to watch these guys fly. And I would argue that this is even cooler than Top Gun because it's real life. But you also get to understand their specific stressors from a medical perspective. You get to realize that these pilots don't have hydraulics in their aircraft, and they're literally flying all by muscle and controlling the aircraft all by muscle. That, along with being able to aim, all the vibrations and noise, and it's super cool to be able to understand that context that they're going through and be able to work with them from a medical standpoint. Again, as a family medicine doc, to be able to, one, make sure that they're okay to do the mission, but more importantly, two, being able to do what they want to do with their families 20, 30 years from then, right? I always tell them that if you can't do what you want to do 20, 30 years from now outside the military, then we as your provider have failed you. But that we're learning about the job, getting to know them from a personal level pays dividends. All right, go ahead, next slide. So another thing, kind of an inside view of this is it gives you an idea. That little grease pen mark on the windshield is literally how they aim. That's their aim marker. And you can see the little bottom little dot. That's because as they fly for 8 hours straight, they start slouching and their aim point drops a little bit too. So that gives you a perspective of one, if the noise is, if you can hear it, but the noise as well as the vibrations associated with it. If you could play it again, if you don't mind. What's even cooler is that that helicopter in the front is actually me flying in Iraq. And so again, like one of the cool things, the pilot's like, "Hey Doc, what are you doing today?" He's like, "Well, nothing. I'm just here. Whatever you need. What can I do to help you?" It's like, "Well, come on, grab your flight gear. We're gonna go fly." And so we went out in the middle of desert Iraq, and he let me take controls, and I got to shoot in a Littlebird. So, I mean, how cool is that? And I would argue, kind of go back to my first slide, is literally the best job in the world, I would argue. All right, go on to the next slide. So we go back to the why, right? So it's really about, one, the fact that we get an opportunity and privilege to take care of the people we do, the people that do things, like the hard things and with little to no recognition. But we have the opportunity to be able to take care of them, not only them and the warfighter, but also their families. And it's a unique privilege and unique opportunity to do so. So on that left photo, that's me and my guys after a run during Memorial Day, and that's the memorial wall for all the people that died either from combat training at the 160th over at Brown Compound. And on the right, that's all my family right there. That's my wife and my 2 little girls. But it gives a stark reminder of why we do what we do, and it's a privilege. It's an absolute privilege to be able to do so. And it just fills your heart with a righteous mission to be able to do what we can to not only take care of the people, but take care of their families as well as that family medicine doc. So go ahead to the next slide. Here's my contact information. If anyone wants to email me, more than happy to do so. Happy to answer questions. Thank you guys for your time.
Man, Colin, that was awesome. Now it makes me want to go do a 3rd residency in family medicine, and now take off after you.
It's never too late. I'm just saying.
My wife would tell you different. The amazing opportunities, definitely the cool guy jobs that are out there to do. If any of you are a little hesitant and you're like, "Is this what my career is going to look like?" You don't have to. Guys like Colin and there's a lot of us that are out there that enjoy those things. I also have a lot of classmates that wanted to go and just do research, and they ended up not doing those things. So these are definitely the cool jobs that we should, a lot of us will seek out.
Final speaker of the night, definitely not the least of these, Dr. Mark Stevens. I had the privilege of working under him when I was a student at USU. And so he was a huge part of my experience of learning of what a family medicine physician could do and the impact he could have in various areas of the military. And so some people might think, oh, he was just a teacher. Well, he impacted so many of our lives. He drew so many of us to family medicine at our medical school, and he's done so many other things. So I'm excited for him to share those things with you. He is now at Penn State, and we'll definitely share his story with that. So thank you, Dr. Stevens, for joining us, and welcome back into the fold of military medicine. I know you miss it, so why don't you tell us a little bit about you and your story?
Thank you, and just thanks to so many people on the call. Mary Alice, it's great to see you. I see Christina Kelly's on the call. Gigi Ray's on the call. Joan Stearman, holy cow. That is great to see Joan on the call. Austin, thanks for this. And everybody, I mean, gosh, what great presentations. I'm going to take a little bit of a different tack at this. You could see in the title slide, I am a very proud family physician, a very proud retired naval officer. My father was also a humanities professor, and I think one of the proudest titles I have now is I'm a professor of humanities in addition to my deaconal role, and also as a professor of family and community medicine. So I'm going to use a technique tonight with you all that's called the public narrative, and that's telling a little bit of the story of me, the story of us, and the story of now. And I'm going to use a technique, I'm going to try to use a technique, spoken word poetry. I really love writing poetry and have fallen back into that habitually. Next slide. So the story of me. From the pulpit of a circuit rider's church, the son of a preacher man, I learned of faith and grace. But my feet, they were rooted in the earth, in the soil of northern New Jersey, the rich dirt of rural Pennsylvania. My hands, they learned to hold a hoe, a shovel, a bridle, working fields, tending livestock. I learned the rhythm of the seasons, the cycle of life and death, long before I knew a cell from a soul. My teenage years were a field of thorns, a compass spinning, searching for true north, academics a struggle. I didn't fit the mold, didn't have the answers, but on the field, on the court, with the team, there I found a language, the language of grit, of sweat, of fighting for the person beside you. And I chose a liberal arts path. not for a clear career, but a broad horizon, to think, to question, to become a whole person, not just a part. I was the first in my family to dream of a white coat, of the letters MD behind my name. But that dream came with a price tag, a weight that could crush a soul. My family, we didn't have a trust fund. We had to trust in ourselves. And so I made a deal, a contract with myself and the country I loved. I joined the Navy, not for adventure, but for a lifeline, a path for a dream. I'm a first generation naval officer, first generation doctor to be. Imposter syndrome was my shadow. The uniform, a foreign skin. Where did the devices go? Which way does the eagle face? I was a student, a sailor, a stranger in a strange land, just trying to find my footing. They told me what to be. You should be a surgeon. You'd be a great cardiologist. Their words, a chorus of expectations, but I needed to find my own song. And so I chose family medicine, especially a specialty that honors the whole person, the whole family, the whole story. From the cradle to the grave, from my residency in the Pacific Northwest to the decks of the USNS Mercy, I was there. One of the first family doctors to ever deliver a baby at the flagship of Navy medicine, the only one to deliver babies at both San Diego and Bethesda. I was building a legacy, one tiny life at a time. I said no to the White House, and I said yes to the Uniformed Services University, to teach the next generation of doctors, of leaders, to share the lessons of field, farm, and of the clinic. From San Diego to Sigonella to the muddy fields of Camp Lejeune, I was there providing full spectrum care, not a flight surgeon, but a full spectrum physician, serving Marines and their families, bearing witness to the costs of conflict and the resilience of the human spirit. And I returned to the Uniformed Services University, rising to lead a department, to be a top 10 program in the nation, to continue to serve, to teach, and to heal.